Hello, and welcome to the October edition of Sepsis Chatter. My name is Sue Von Bossi, and I am an RN Quality Consultant for Registry Partners Incorporated. Today's presentation will focus on determining the presence of initial hypotension in the patient with severe sepsis or septic shock. The information included in this presentation is based on the CMS Specifications Manual for National Hospital Inpatient Quality Measures discharges July 1st through December 31st, 2022. The goal of this presentation is to give the attendees the tools to identify the clinical criteria and the acceptable time frame that determines the onset of initial hypotension for the pregnant and non-pregnant patient. Select the correct date and time of onset, including when outside documentation is present. Determine when hypotensive values should be excluded. And finally, differentiate between initial hypotension versus persistent hypotension data elements. Before we look at specific guidance and examples, I'd like to review the data element definition and suggested data collection question. Initial hypotension. The definition: documentation of the presence of initial hypotension within the specified time frame and prior to the completion of the target ordered volume of crystalloid fluids. Suggested data collection question: was initial hypotension present within the specified time frame? Value 1, yes, initial hypotension was present within the specified time frame. Or value 2, no, initial hypotension was not present within the specified time frame or unable to determine from the medical record documentation. Let's take a look at the specified time frame for assessing initial hypotension. To determine the presence of initial hypotension, there needs to be documentation of two hypotensive values within the acceptable time frame of 6 hours prior to through 6 hours following the onset of severe sepsis or septic shock. For this data element, the two hypotensive values do not need to be consecutive. However, they do need to occur within 3 hours of each other. Keep in mind that in order to answer value 1, yes, to this data element, the definition of hypotension requires that both hypotensive values must occur prior to the completion of target ordered volume of crystalloid fluids. When abstracting blood pressures for this measure, the priority source is when the blood pressures were taken or recorded. A narrative note should only be used if the documentation supporting when they were actually taken cannot be found. So how do we determine the correct date and time for the onset of initial hypotension? The guidance tells us to use the earliest date and time of the second hypotensive value documented within the acceptable time frame. But it also has to occur within 3 hours of the first hypotensive value. Let's look at the example that includes multiple hypotensive values documented within the acceptable time frame. The onset of severe sepsis is at 9 o'clock. The acceptable time frame to be looking for initial hypotension is between 12:02 at 3 o'clock in the morning through 12:02 at 3 o'clock in the afternoon. Remember that we're looking for the second hypotensive value. So if we look down our list, we see that there is a map of 62 at 8 o'clock. The next hypotensive value is at 9:15 with a blood pressure of 89/64. In this scenario, we would select the 12/2/22 9:15 as the initial hypotension date and time. This would be a good time to point out that we do need to give special consideration to our new patient population, the pregnant patient, defined as pregnant 20 weeks through 3 days post-delivery. The criteria that is considered hypotensive for the pregnant patient is a systolic blood pressure of less than 85 millimeters of mercury, as opposed to the 90 millimeters of mercury for the non-pregnant patient. All other requirements that determine initial hypotension would be the same. Let's go over this example to determine initial hypotension in a pregnant patient. This patient, who is an estimated 36 weeks gestation, was diagnosed with severe sepsis per ED/MD documentation at 1500. Blood pressures of 80/55 at 1400, 86/66 at 1530, and a MAP of 62 at 1600 were measured. We would accept the 80/55 at 1400. However, 86/66 at 1530 is not considered abnormal for this patient population. So we would have to exclude this in determining initial hypotension. So then we would move on to the MAP of 62 at 1600. So yes, this patient does have initial hypotension, and you would choose the 1600 for the earliest date and time that initial hypotension was met. I did want to briefly mention the initial hypotension criteria for the non-pregnant patient, since we're all pretty aware of this, but I did want to throw it out there. Systolic blood pressure of less than 90 millimeters of mercury, or the MAP of less than 65 millimeters of mercury. Also, if we have a systolic blood pressure decrease of 40 millimeters of mercury, it must be documented as related to infection, severe sepsis, or septic shock by an MD, a PA, or an advanced nurse practitioner. For this next example, I would like to present a scenario where initial hypotension would not be present in a non-pregnant patient. Septic shock was met by clinical criteria at 12 o'clock. Acceptable time frame to assess for initial hypotension would be 6 a.m. through 6 p.m. on that same date. The full target volume of normal saline, 2100 cc's, was administered from 7:30 and was complete by 8:30. On the same date, blood pressures were documented as follows: BP of 89/60 at 6:30, a MAP of 70 at 7:30, and a MAP of 63 at 8:45. But we would select value 2, no, for initial hypotension present. The full target volume of normal saline was complete at 8:30, and this is prior to the second hypotensive value at 8:45. Remember that both hypotensive values must occur prior to the completion of the full target volume of crystalloid fluids. When assessing for initial hypotension, when will we exclude hypotensive values? The following guidance instructs us not to use hypotensive values in the following scenarios: in the OR, during dialysis, during CPR, during conscious sedation, during a procedure, interventional radiology. Also, when you're evaluating for orthostatic blood pressures. Also, if hypotensive values are due to the following, do not use them. If the MD has documented that it's normal for that patient, is due to a chronic condition, is due to a medication, the abnormal value or reference to the abnormal value must be in the same documentation, the same sentence or paragraph. And also, it states, do not make inferences. Let's review an example of an excluded hypotensive value. For this patient, the onset of severe sepsis was at 10 o'clock on 12/12, with mechanical ventilation as the last indicator met. The patient developed hypotension starting at 9:50 with a MAP of 62, and at 9:59, the blood pressure was 88/60. At 10:30, the anesthesiologist documented that this patient became hypotensive and required fluid boluses after receiving the max dosages of propofol and Versed for intubation. In this example, there's provider documentation in one paragraph that states the hypotension is due to medications. That would exclude this documented hypotensive values, and we would answer no to initial hypotension present. I'd like to review one last example that demonstrates acceptable documentation that excludes initial hypotension. This is a pregnant mom who presented to the OB emergency clinic and was found to have met clinical criteria for severe sepsis at 1 p.m. on 12/10/22. Her blood pressures were as follows: 1230, 80/60, 1250, 77/55, 1310, 72/50. At 3 p.m. on the same date, the OBGYN documented that the patient was hypotensive and that he suspected hypovolemia due to ongoing hyperemesis gravidarum during this entire pregnancy. So the documentation at 3 p.m. supports the fact that the hypotension was suspected to be due to a non-infectious source, and we would exclude any hypotensive values that would indicate initial hypotension for this patient. Let's change direction for a minute. For patients who meet the criteria for initial hypotension prior to arrival, how do we abstract the correct date and time of onset? The guidance states that if the patient meets criteria for initial hypotension in an ambulance, for example, and the first blood pressure taken in the ED was also hypotensive, then we would select value 1, yes, for initial hypotension present, and select the date and time of patient arrival to the emergency room. On the other hand, if the patient meets criteria per EMS documentation for initial hypotension, but the first blood pressure taken in the emergency room is within normal limits, then we would answer value 2, no, to the initial hypotension data element. So in this scenario, we would answer no to initial hypotension. The patient arrived to the ED on 12/15/22 at 10 o'clock via EMS. The EMS run sheets include the following. At 9:25, the blood pressure was 75/55. At 9:30, it was 78/60. At 9:45, it was 110/70. The first blood pressure that was taken in the ED was 120/80 at 10:05. Because the first blood pressure was within normal limits in the emergency room, we would select value 2, no, for initial hypotension present. So what if the patient is a direct admit from an urgent care clinic? The guidance regarding initial hypotension met outside of the hospital still applies. However, we would abstract the arrival date and time to the unit for the onset of initial hypotension. In this example, the patient arrived to the telemetry unit on 12/1/22 at 5 p.m. via EMS from the urgent care clinic due to sepsis and hypotension. Blood pressures per the urgent care clinic notes are as follows. At 4:30, blood pressure was 75/55. At 4:40, it was 78/60. No blood pressures were taken by EMS en route. However, the first blood pressure on the unit was 80/62 at 5:35 p.m. Select value 1, yes, for initial hypotension present and use the arrival date and time of 12/1/22 at 5 p.m. for the onset. How do we determine initial hypotension when only one hypotensive value occurs prior to arrival? Let's look at the following scenario. On 12/2/22, this patient was transported to the ED from home. EMS vitals include the following blood pressures. At 4:30, blood pressure of 120/80. At 4:40, the blood pressure was 78/60. The patient arrived to the ED at 4:55 p.m. that day. The first blood pressures taken in the ED include at 5 p.m., a blood pressure of 110/60. And at 5:25, there was a blood pressure of 88/55. So this patient did meet the clinical indicators for initial hypotension. One was the hypotensive value that was documented by the EMS at 440, which was 78/60. The second hypotensive value, which is the one that will determine the date and time of onset of initial hypotension, was at 5:25 with a blood pressure of 88/55. So in this case, we would select value 1, yes, for initial hypotension, and 12/2/22 at 5:25 p.m. for the date and time of onset. To be clear, we wouldn't use the first blood pressure measured on arrival necessarily to determine initial hypotension. The second hypotensive value documented within the acceptable time frame and within 3 hours of the first hypotensive value, which was in EMS documentation, would determine the onset of initial hypotension. For this scenario, we would abstract the date and time that it actually occurred. Also, as a side note, using the arrival date and time for initial hypotension onset applies to when both criteria for initial hypotension are met prior to arrival to the emergency room or to the inpatient floor. In closing, I want to leave you with a quick comparison of initial hypotension versus persistent or new hypotension. Initial hypotension is determined by 2 hypotensive episodes within the time frame of 6 hours prior to through 6 hours following the onset of severe sepsis or septic shock. The 2 hypotensive values do not need to be consecutive, but they do need to occur within 3 hours of each other. And they also need to occur within the acceptable time frame. Both of the hypotensive values must occur prior to the full completion of the full target volume of crystalloid fluids. To assess for persistent or new hypotension, the acceptable time frame is the hour following the completion of the target ordered volume of crystalloid fluids. 2 blood pressures are required, and they must be consecutive. Please refer to the resources listed for further information related to the SEP1 measure. This concludes today's presentation of Sepsis Chatter. Please join me next time to review severe sepsis and septic shock, 3 triggers for initiating crystalloid fluids. Thank you very much for attending, and happy abstracting!